Hey everybody, this is Alec Weir. When I became academic chief, the feedback I got most commonly was that people wanted to do more case discussion. Alright? And fortunately for us, we have a lot of interesting cases we get to see. But unfortunately, we just don't have enough time in conference to talk about all of them. So I thought I'd give this a try. This will be a hopefully weekly morning report with an interesting case that we get to see either at Parkland or Children's or one of the other EDs we rotate through. So let's go ahead and give this a shot. This is the case of, I'm going to need a doctor. I took a bunch of dope. So this is a Sunday night. Approximately 45-year-old male presents to pod 3 unresponsive. Get the sort of flyby report from EMS as we're moving him over. He's tachycardic, his glucose was normal, and he's non-responsive to sternal rub. ABCs, getting him hooked up to the monitor, we're getting our IV access. I place a nasal pharyngeal airway. All right, and we pre-oxygenate with 4 liters of nasal cannula as well as a BVM. Decision was made to intubate because of his lack of response. We used etomidate and rocuronium. Intubated with a MAC4, 8-OET tube, 22 centimeters at the lip. All right. Now for the rest of the story. He's a 45-year-old male. Is being arrested by police department. In the back of the police car, the patient states, "I'm going to need a doctor. I swallowed a bunch of dope." He then became unresponsive with the police department. EMS was called, and when they arrived, they witnessed one episode of a tonic-clonic seizure-like activity, and he was given 2 milligrams of IM Ativan. So now, taking a look at the monitor, his tachycardic, he's 120s to 140s. He's a little hypertensive. His respiratory rate is 15. He's setting 100%, and he's normothermic at 36.8. All right, so what's next? High fives, intubated, calling the MICU. It's an easy disposition. Put him in the back corner, forget about him. What do we want to do for our workup? All right. Labs, we have a guy with a reported intoxication with a change in mental status and new seizure-like activity. Urine tox is ordered, CT head, chest x-ray to check your tube placement, IV fluids for his tachycardia, and an EKG. All right. Ordered the EKG, most likely going to be sinus tachycardia, right? He took some cocaine, and this is the EKG we get. All right. Wide complexed tachycardia, right around 150 beats per minute. Concern for VTAC, SVT with aberrancy. But I think right here in AVL, we do have P waves, okay? So that's a good sign. So what else? Our other concern is toxicologic, all right? So QRS is 138, QTC 596. So what did I do? This is my intern year. I gave an amp of bicarb, 50 milliequivalents, and I rechecked an EKG. Looks a little different. QRS is still wide. P wave's still present in AVL. P wave now in V3, okay? And the QRS is a little shorter. It's 130 now. QTC still prolonged, 587, okay? So then I started him on a bicarb drip. 1 amp of bicarb help, let's put him on a drip. 150 milliequivalents and 1,000 mLs at 150 mLs an hour. This is the dosing that we do here at Parkland for these drips when you go through your order set. And I also put him for the toxicology consult. All right. So this is his third EKG after about an hour. QRS is improved. We got P waves before every QRS. All right. And our QRS now reads at 90 with a QTC of 464. This is the note that was written by our toxicologist. Listen to your toxicologist, smartest guys we got. So they mentioned the bicarb drip that I had started the patient on may help with to narrow the QRS duration related to the cardiac cell sodium channel blockade. But their advice was 1 to 2 boluses of bicarb while running a rhythm strip to see if QRS narrows. If so, keep giving bicarb. All right. If it's not effective, the drip probably won't be either. So this is how it should have been done. Looking back, talking with the toxicology department, 2 to 3 50 milliequivalent amps of bicarb while running a rhythm strip. All right, is your QRS improving? Is it getting small? Is it getting shorter? If so, repeat the boluses until your QRS returns to normal. All right. If there's no effect on the QRS from the bicarb, other causes of wide complex tachycardia should be investigated. Okay. So, and here's why. Here's some math, all right? So the recommendation is to bolus 100 to 150 milliequivalents of bicarb and see what happens with your QRS. That drip that I ordered only provides 22.5 milliequivalents per hour, so nowhere near the amounts that we were giving when we were giving our pushes. Okay? So why does this happen? When we talk about cocaine, we most commonly think of our cocaine chest pain, that coronary artery spasm that you see down here. Or even you can think about your thrombosis or MIs, because cocaine use is an independent risk factor for ACS. Your hemorrhagic strokes, your aortic dissections, all possible in this guy. Altered mental status, new seizure due to the sympathomimetic effects of cocaine. But cocaine is also an antiarrhythmic. It has sodium channel blockade. And that's why you can see QRS widening similar with your TCA overdoses. And you also get QT prolongation due to its effects on potassium channels. Okay? Hospital stay, not that impressive. Admitted to the MICU. Cards was consulted for a possible STEMI. All right, so they see that on this third EKG. Echo without wall motion abnormality. Enzymes continue to be negative. So this is their concern for STEMI here. Anteriorly, possible ST elevation. All right, maybe some sort of depressions out laterally, but again, no wall or inferiorly, excuse me. But again, no wall motion abnormalities on their final echo, and enzymes continue to be negative. He was extubated on hospital day 2 and discharged on hospital day 3. On case follow-up, he did actually present about 12 days later with generalized fatigue thought to be secondary to cocaine washout and his lack of cocaine use. All right. So there'll be a couple of links that'll be sent in this email as well. One of them bears special mention here. This is a write-up by one of our new second years, Dr. Jessame, on a very similar case as to the one that was just presented. Okay? So that wraps up our first edition of Morning Report. So if anybody has anything they want to add, anything I missed or any mistakes I made, please let me know. This is for everybody's educational purposes, including my own. And if you guys like this, hopefully we can keep this going. So keep your eyes open for those interesting cases, interesting EKGs, radiology, metabolic derangements, resuscitations, things that you'd like to share with the residents outside of, the whispers of the back halls. All right? Just let me know. All right, guys. Thanks.